Hello.
Hello?
Hello. Mrisi auntie.
I'm well. You no longer want to come and see us, Mrona wangu.
We really want to come and see you, but nyaya dzema-lockdown ndoza dzakambotipresa but touya tinouya manje manje muchationa zvinhu.
Alright, Moriri say?
Muriri right zvekuti.
Any new family members for us?
Hapana apa auntie. We've been trying but kubva pandakaningirina ndakabvisa depo last year but we've been trying hapana chiri kutomboita.
Don't worry, Mrora. I hear Depo does that at times.
Mavaona here dhokota, mavaona chiremba. Antika, I wonder why mustombori doctor zvenyu because uzivi hwenyu ka muri makadini henyu kuita doctor name kana maida kuita doctor zvedhepo zvamaundudza izvi.
You can ask around.
Auntie. But kuseka zvangu. But honestly, I'm really stressed.
Don't worry, Mrora wangu. Ask the doctors. But I think eventually you will have a baby. Usanesek.
Alright, auntie, pari bore. Gaini mboita andi shande mbichana.
Alright, Mrora wangu.
Dear doctor, I'm a lady age 32. I have 2 babies. I've been on Depo-Provera but stopped using it a year ago so that we could try for another baby. But I'm failing to have a baby. My aunt is saying it might be the Depo. Is this true? And are the effects of using it permanent? Please help me.
Contraception refers to the various methods that are used to prevent pregnancy in a woman who is sexually active. So we are saying a woman is having sex regularly, but we don't want her to fall pregnancy. So the various methods that are there in place to stop that woman from falling pregnant, despite her having sexual intercourse, that is what is called contraception. All right, there are many different types of or classes of contraception that are available on the market. We can broadly classify them into reversible methods and non-reversible methods. So with the reversible methods, what we are saying is we give you some method of family planning or contraception with the intention of going back to fertility sometime in future at a desired time in future. So we give you family planning now. You have a contraceptive effect, say for 10 years, say for 5 years. But after that, when you stop using that method, you go back to fertility. Fertility is restored. Then you get what are called non-reversible methods, where these ones, we use them in a patient who has completed their family, because they are not designed to be reversible. They're designed to be permanent. So we have under that class, we've got bilateral tubal ligation, which means when this is what happens when we tie the woman's tubes. We cut and tie the woman's tube. This is designed to be permanent. And then you also get in men where we tie their sperm ducts. It's also designed to be permanent. In some situations, of course, we can be forced to try and undo the operation, but this is very difficult and is associated with some complications, and in some cases it may actually fail. So under reversible contraceptions, you've got the oral methods of contraception, which is the common tablets that women take. We've got secure and control tablets. Then we've got the injectables. The popular one in Zimbabwe is the Depo-Provera, which women call Depo. And then you've got the implants, and there are various types of implants that have been used or are being used in Zimbabwe. Most people are familiar with the no plant, and then we had, and we still have the Jadel, and then the new kid on the block is the Implanon. We'll talk about those in detail as we go. And then there are the barrier methods, which is the condoms, which we have the female condoms and also the male condoms. When it comes to the implants, like I said, our women were familiar with what is called the no plant. No plant is inserted on the woman's upper arm, just on the side that is closest. We call it the medial aspect of the woman's upper arm. No plant had 6 rods. It has since been phased out. The reason why it was phased out is because it was easy to put the 6 rods, but when it comes to removing them, it was very, very difficult. And quite often you would get the doctor removing, maybe out of the 6, the doctor will be able to remove 4 of those and fail to find the other 2. And also the process of removing those 6 was associated with a big scar. So people moved away from no plant. And then we had Jadel. Jadel, we are looking at basically the same drug as in no plant, but this time it's got only two rods, which technically easy to insert, technically easy to remove. We have less incidence of the doctor or the nurse failing to find the other rod. So with Jadel, it's currently available on the market. It is designed to last for about 5 years, but take note, you can remove it anytime you either have problems with it or when you wish to have another child. Jadel has got what we call levonorgestrel, which is a progesterone. It only has one drug in it, which is a progesterone, which means it can be used by people with mild hypertension or mildly elevated BP. They can still use the Jadel. The other advantage of Jadel is that the woman doesn't have to remember. The woman doesn't have to remember to take. Once we insert this, and before we have removed it, she's covered in terms of contraception. She doesn't have to remember every day, and it's also not affected by things like vomiting, diarrhea, and so on. All right. The disadvantage of Jadel is that, number one, it has to be inserted by a trained somebody. It also has to be removed by a trained somebody. So that takes away the power from the woman. Ideally, we want the woman to have 100% control of her contraception, which means she takes it when she wants, she stops it when she feels like, and it can still be effective. That's the kind of contraception that we want. But with Jadel, women do not have that power. They have to go to a trained somebody when they want it inserted or when they want to remove it. Some of our women have complained about weight gain on Jadel, and then sometimes you get some irregular periods. Either the woman stops having periods altogether, or the periods become irregular, or the woman bleeds for longer than expected. So that's the challenge. Those are some of the challenges with Jadeo. But we also worry in some groups of women who are prone to developing keloids. The fact that we are putting this just underneath the woman's skin, we are creating a small scar there. So in women that are prone to developing keloids, she can also develop keloids because of the process of inserting and also removing the Jadeo. And then some of the women, if the sterile technique is not maintained, the woman can actually develop infection just underneath the skin on the area that would have put the Jadeo. And then apart from the no plant and the Jadeo, the new kid on the block, like I said, is called Implanon. And Implanon comes with its applicator. It has got only one of these rods, and it's designed to last for 3 years. The class of drugs that is found in the Implanon is still the same. It's still a progesterone that is found in the no plant, that is also found in the Jadeo, but it's a slightly different progesterone called etonegestrol that is found in Implanon. The side effects, the problems and the advantages are basically the same as for Jadeo. So because Jadeo, Implanon, they are not affected by factors like vomiting, they are not affected by things like diarrhea, they are not affected and then by the patient having to remember, or if a patient forgets, the effectiveness is very, very high. So we are looking at over 99% effectiveness of the implants. Okay. Intrauterine contraceptive device, or sometimes people will abbreviate it as IUCD, intrauterine contraceptive device. It's popularly known as the loop. So what we are basically doing with the loop is we are going to put this small T from there to there, and you go down all the way up to there. So we are inserting this T into the woman's womb, and you see that this T is actually lined. So it's a hard plastic that is lined with a copper wire. Now this copper wire releases some what we call copper 2 plus ions, some ions from the copper. And it is these ions that change the environment within the whole uterus to make it unfavorable for the sperm, to make it unfavorable for implantation. That's how it works. There are no hormones in the copper tree. It's just those copper ions that are going to give us the contraceptive effect. So for those patients that have got problems with BP, problems with diabetes, problems with weight, this is one thing that those women should be looking at. So if we have inserted the copper T in a woman, in the end you get something like this. You can see this is the woman's womb, and the copper T is nicely embedded inside the woman's womb. And you see that there are these little strings that we leave hanging in the vagina. They are used for two reasons, for two purposes. The first purpose is for us to be able to remove it when the woman no longer needs the contraception. We just pull these strings and the IUCD comes out. It's also used by the woman to check if the IUCD is still in place, if the loop is still in place. The advantages of loop is that it's actually long long acting. It lasts for a very long time. This can give you contraception for up to 10 years. So that's a very good long-term method of contraception. And some people can even push it to 12 years. There's evidence to say even beyond 10 years, you still get contraceptive effect. The woman doesn't need to remember to take this. Once we've inserted it, that's it, until we remove it. It doesn't have any hormones, so it's okay for women with other medical conditions that would not allow them to take certain hormones. The problems with the loop are that if the woman has got multiple sexual partners, the risk of getting severe infection within the womb is amplified. As you know, once you have a foreign body in any part of your body, then if you get an infection, you're more likely to get infected. That's number one. Number two, the infection is more likely to be severe. So would really discourage a woman that has got multiple sexual partners from using a loop. That's disadvantage number one. Disadvantage number two is sometimes the loop actually comes out, and the problem there is the woman might not even notice that the womb has actually slipped out, especially if she's going to have very heavy periods with clots. So this can be a problem. It might actually come out, and the woman does not realize that it has actually slipped out. And then we also have challenges with heavy, painful periods. This usually happens in the first 3 to 6 months of insertion of the loop. So, and we normally just tell our patients just to hold on a bit. After 6 months, usually the body gets used to the loop, and the thickness of the inner lining of the womb tends to go down because of the effect of the copper 2 ions over time, such that the periods become less, or they go back to normal, and they become less painful as we go. And then if I were to put 5,000 of these, one of them is going to pay for it, which means I'm going to go through the womb and perforate the woman's womb. It's a very rare complication, but people have to know that it's a possibility. Sometimes you can actually get spontaneous perforation, where the loop actually goes through the wall of the womb, and sometimes you get women having, a woman who had settled, whose periods had settled, if they start having new onset heavy bleeding or new onset pain, you want to do a scan and check if the loop is still in place. But like I said, these are very, very rare complications, so people should not panic. It still remains a very good method of contraception. The benefits would outweigh the potential risks. Next method of contraception that we are going to talk about is the Depo-Provera. So it's got a progesterone, a different type of progesterone from the one that is found in the implants and the secure. So this one has got what we call medroxyprogesterone acetate, so 150 milligrams of the medroxyprogesterone acetate. So in Zimbabwe, this is the injectable of choice. So the woman gets an injection every 3 months. Every 3 months, And the advantage of being that, one, is very cheap, it's widely available, and our doctors and nurses and even some of our patients have got a lot of experience with DEPO. It's been around for a long time now. In other countries, they've got other types of injectables, so I'm not going to talk about those, because let's talk about what is relevant to our people in here in Zimbabwe. The advantage, like with DEPO, is that there's only one hormone, that is a progesterone. Unlike the control pill, which has got two hormones, estrogen and progesterone, this one has one hormone, which is the progesterone. So the same advantages that I talked about, and the implants will come into play. It can be used by people with other medical conditions, unlike the control pill, which has got estrogens. The woman doesn't have to remember. Once they've been injected, that's it. We see you after 3 months. The other advantage of DEPO is that in women that have got very heavy periods, this DEPO is associated with reduced flow on periods. And in fact, 50% of our patients will actually not be having periods. They develop what we call amenorrhea, which is good. The disadvantages with DEPO is that some women, like I said, that some of the women might not have periods, but some women are not comfortable with not having periods. They feel like their system is not functioning well once they miss a period or two. So that can be a disadvantage in some women who are particular about their cycles and their reproductive system. If a woman, particularly if a woman has used DEPO for a long time, beyond a year, for example, and they stop the DEPO and they now want to have a baby, fertility may take time to come back. So there's delayed return to fertility with Depo-Provera. And this delay can go up to a year or so before they start having periods again, before they start ovulating again, before they become fertile again. But don't despair. If you are in a hurry to have a baby after DEPO, just go to your gynecologist. They know how to bring back your fertility. So how does the DEPO work? The DEPO works at various levels. In fact, all contraceptives that have got progesterone in them, they work at the level of the ovary. They stop or inhibit ovulation. That's number one. Number two, they also create an environment. Progesterone creates an environment within the endometrium, within the inner lining of the womb, an environment which is not favorable for implantation. So even if the woman goes on to ovulate, the egg is fertilized, when it comes to implantation would not be successful. That's number two. Number three, progesterone works by thickening the mucus that is produced by the cervix. So that makes it difficult for the sperm to penetrate into the womb. So those are the ways in which the progesterone-based methods of contraception do work.